Hello! Good afternoon. I am Dr. Rosalyn Valerie Cortez Villanueva, and this is Massive Transfusion, the approach to the patient with massive bleeding. These are our objectives for this afternoon. So, for just a bit of historical trivia, military conflict has pretty much shaped the practice of massive transfusion starting in World War I, wherein whole blood was used for transfusion, while in World War II, freeze-dried plasma was the primary transfusion product. After World War II, fractionation techniques were developed and separated whole blood into different components, namely our packed RBC, our plasma, platelet, and cryoprecipitate. There have been various definitions of massive blood transfusion as published in medical literature, such as the following. However, the latest guidelines for massive transfusion by the Association for the Advancement of Blood and Biotherapies defines it as follows. So, transfusion of greater than 8 units of red blood cell in an adult in less than 24 hours, acute transfusion of 4 units packed RBC within 1 hour, a loss of 50% blood volume in 3 hours, or a bleeding rate of greater than 150 ml per minute. The classic definition of massive transfusion was defined as a transfusion of 10 units of blood in a 24-hour period. However, multiple flaws have been identified with this definition, the most significant of which was the survival bias, that the patient must actually survive 24 hours to meet this definition. So, the truly massively hemorrhaging patient who dies within the first several hours is not captured and the intensity of resuscitation is not recorded. So, scoring tools were developed for a better definition of massive transfusion. The CAT or the critical administration threshold is described as CAT positive when the patient receives 3 or more units of packed RBC within any 1 hour time frame during the first 24 hours after injury. The resuscitation intensity score encompasses all resuscitation fluid given to a patient within 30 minutes of arrival, with 1 unit being equal to 1 liter of crystalloid, zero point 0.5 liters of colloid, and 1 unit each of packed RBC, plasma, and apheresis platelet. With the increasing utilization of cold stored whole blood in modern resuscitation, a whole blood massive transfusion score was recently proposed, defined as the sum of each unit of RBC plus 3 for each unit of whole blood transfused, with a score threshold of 7 defining massive transfusion. So CAT-positive patients, RI score of more than 4, and WBMT of more than or equal to 7 have been found to have an increase in overall mortality. Massive blood loss is encountered in various situations, not only trauma, but surgeries, GI bleeding, obstetric hemorrhages, and others. Thus, a timely recognition and efficient management is essential for a successful outcome. So, the principles of massive blood loss would depend on the management of our intravascular volume loss and the loss of our blood components. The management of our intravascular volume loss is a vital component of our management because physiologically, hemodynamic compensatory mechanisms are able to maintain vital organ perfusion only until about 30% of total blood volume loss. And anything beyond that, and there would be a risk for hypoperfusion. Hypoperfusion with inadequate resuscitation at this stage would eventually lead to shock. But on the other hand, overzealous resuscitation can also lead to an increased arterial and venous pressure, which may be deleterious as well, as it can dislodge hemostatic clots and cause more bleeding. The management and loss of our blood components is best managed by following the massive transfusion protocol. With increasing loss, dilutional anemia and later dilutional coagulopathy would set in. The use of plasma substitutes such as your crystalloids and colloids may have a direct effect on the coagulation system, especially if it is used in volumes of more than 1.5 liters. In a study of surgical patients, hemostatically critical levels of your platelets, fibrinogen, and coagulation factors were reached at more than 200% of blood loss. So therefore, it is generally recommended that the replacement of your blood components be guided by your laboratory. But in situations of massive and continuous losses, your laboratory testing may take too long of a time and treatment is delayed. And so, a protocol-based empirical replacement of coagulation factors is recommended in these situations. With better understanding of the pathophysiology of hemorrhagic shock, resuscitation of patients with massive bleeding has advanced from a reactive supportive treatment to use of a more proactive standardized protocol called our massive transfusion protocol. Studies have shown an improved survival using a higher ratio of FFP to RBC transfusion. The MTPs are designed to interrupt the lethal triad of acidosis, hypothermia, and coagulopathy that develops with massive transfusion. Transfusion of fresh whole blood would seem ideal, but the time required for safety testing on blood may take too long. And administering the red blood cells, coagulation factors, and platelets together maintains the physiologic constitution of blood and prevents deficits of one or more of its components. The massive transfusion protocol describes the process of management of blood transfusion in major bleeding episodes and assists the interactions of clinicians and blood banks to ensure the judicious use of blood and blood component. By developing locally agreed and specific guidelines that include clinical, laboratory, and blood bank responses, clinicians can ensure effective management of massive blood loss and thereby improve outcomes. The massive transfusion protocol forms the central core of this resuscitation and involves the rapid administration of large volumes of blood products, including our RBCs, plasma, platelets, cryoprecipitates, and whole blood. This is activated by a clinician in response to a massive bleeding, and it has a predefined ratio of RBCs to FFP and cryoprecipitate to platelet units in each pack, with a ratio of 1:1:1 or 2:1:1. Generally, this is activated after the transfusion of about 4 to 10 units of packed RBC. But once the patient is in this protocol, the blood bank would then ensure the rapid and timely delivery of all the blood components together to facilitate the resuscitation. This would reduce the dependency on laboratory testing during the acute resuscitation phase and would also decrease the communication that is needed between the blood bank, the lab, and the doctor. This transfusion strategy has been recommended to prevent hemodilution and to restore coagulation function closer to normal and potentially providing a better control of the hemorrhage and improving outcomes. The MTP is, however, not without its limitations. So, number one, it is not standardized, and the trigger for initiating the protocol, as well the optimum ratio of the RBC to FFP and platelet ratio, is still controversial. Therefore, the practice actually varies from center to center. And it can also lead to wastage if the MTP is triggered prematurely or in a non-massive blood loss situation. It can actually lead to wastage of your blood products. A review of two different types of MTPs was done, namely trauma and non-trauma MTPs. Table 1 shows the different types of hemorrhages and the ratios of blood products transfused. Non-trauma MTP conditions would include post-operative, gastrointestinal, intraoperative, abdominal, vascular, obstetric, CNS, pulmonary, and skin and soft tissue bleeding. The trauma MTPs have a ratio of 1:1 for red blood cell and plasma, whereas non-trauma MTPs would have a ratio of 1.8:1. It was noted that the total number of red blood cells, platelet units, and plasma units transfused did not actually differ by the type of hemorrhage, and that there was no significant differences in the RBC to plasma ratio transfused for the different types of hemorrhage, both trauma MTPs and non-trauma MTPs. Mortality also did not vary significantly by the type of hemorrhage or by ratio of RBC is to plasma that was transfused. 22% died within 24 hours of MTP activation, including 30% from trauma and 21% from non-trauma cases. All in all, the RBC is to plasma ratio, number of platelets or plasma, or the use of platelets during an MTP did not affect the 24-hour mortality, and only the number of RBC units transfused had a significant association with 24-hour mortality during an MTP. It was found that with each additional RBC transfused, the patients had a higher chance of dying within 24 hours. But the number of RBCs transfused most likely reflects the clinician's assessment of the severity of the situation and does not necessarily imply that it was the RBCs that affected the 24-hour mortality. Here is a sample of a massive transfusion protocol starting with our actively bleeding patient seen at the ER. Blood requests and specimens are sent to the blood bank and is also informed of this patient. Initial fluid resuscitation is also happening at this time with the use of your colloids and crystalloids or an uncross-matched RBC if available. The ROD would then determine if the patient would fulfill your criteria to activate your MTP. The MTP criteria is seen in box A as the ABC scoring system consisting of your heart rate, your BP, a fast or focused assessment using sonography in trauma, or if there's an obviously penetrating injury. The MTP is activated at this time. As soon as the blood group is known, switch to an ABO-specific uncross-matched RBC. Two large-bore IV needles should be inserted and tranexamic acid can also be given simultaneously. During this time, the blood bank is preparing your box 1 consisting of your 4 units of packed RBC, 4 units of FFP, and 4 units of platelet concentrate with a 1:1:1 ratio. Packed RBC is given as fast drip while your FFP and platelet concentrates are being transfused in the other line. After box 1 is consumed, you should give your calcium chloride or calcium gluconate at the central line or peripheral line respectively. At this time, the blood bank will confirm with the OR or the RIC if the MTP is still confirmed and then proceeds to prepare your box 2. While the blood bank is preparing your box 2 consisting of your 4 units of packed RBC, 4 units of FFP, and 4 units of platelet concentrate, you can now check for your CBCs to check your hemoglobin hematocrit, check for your PT-PTT, and fibrinogen. The blood bank will again contact the OR or the RIC to confirm if the MTP is still in place. And this process continues until the ROD terminates the MTP after your resuscitation targets have been achieved. So your targets of resuscitation would include a MAP of equal to 60 mmHg, hemoglobin of 7 to 9, INR of 1.5 to 2, platelet counts of more than 50,000, pH of 7.35 to 7.45, a core temperature more than 35 degrees, a base deficit of less than 3, and lactates of less than 2. Once your targets have been achieved, the blood bank should be informed that the MTP has ended and this would stop the process. And we should now switch to a point-of-care based transfusion. Massive transfusion does not come without complications, which can be either immediate or late. So problems arising from volume resuscitation would include if there is inadequate resuscitation, leading to hypoperfusion, leading to lactic acidosis, to your SEERS, to your DIC, and multi-organ dysfunction. On the other hand, if there is overzealous resuscitation, this can lead to your transfusion-associated circulatory overload or interstitial edema. Dilutional problems such as dilutional coagulopathy, because during hemorrhagic shock, there is a fluid shift from your interstitial to your intravascular component. That leads to dilution of your coagulation factors, which is also accentuated when the lost blood is replaced with coagulation factor deficient fluids. So for problems related to transfusion of large volumes of stored blood, there can be citrate toxicity because hypoperfusion or hypothermia associated with massive blood loss can decrease the rate of metabolism, leading to your citrate toxicity. And unmetabolized citrate can lead to hypocalcemia, hypomagnesemia, and worsen the acidosis. Calcium supplementation is thus required in most cases of your MBT. The development of your hypokalemia would depend on the underlying renal function, severity of your tissue injury, and the rate of transfusion. Transient hyperkalemia can be seen at transfusion rates exceeding at 100 to 150 ml per minute. Factors contributing to your hypothermia would include infusion of your cold fluids and blood products, but this may be alleviated with the use of your blood warmers. Citrate also binds to your magnesium, leading to your hypomagnesemia. And after 2 weeks of storage, your packed RBCs would then have a pH of below 7, and acidosis directly reduces activity of both your extrinsic and intrinsic coagulation pathway. A decrease of your pH from 7.4 to 7 reduces the activity of your factor 7A and factor 7A tissue factor by over 90% and 60% respectively. So late complications would include your respiratory failure, your SEERS, sepsis, and other thrombotic complications. So how do we prepare for massive bleeding? So we present some important points to remember. So use large bore IV access. 2 peripheral cannula should be used. There should be the availability of your warming devices for both in-fluid warmers and surface warmers. There should be a continuous core temperature monitoring, invasive arterial pressure monitoring, and use of adequate amounts of your colloids, crystalloids, and infusion sets and IV calcium preparations should also be ready. There should be a good communication with your blood bank about the emerging massive blood loss situation. There should be adequate manpower for sending samples and getting your blood and blood products. A point of care testing is highly desirable, such as your ABGs and rapid infusion pumps or pressure bags to speed up the fluid infusion rate. And of course, post-operative intensive care, including your mechanical ventilation and a continuous hemodynamic monitoring. In summary, I have presented the definition of massive transfusion, including some scoring tools, the principles of management, and presented a sample of massive transfusion protocol with its expected complications and some reminders for preparation. So the management of massive blood loss requires a quick concerted effort by many medical and paramedical members, and understanding the complex pathophysiology of massive blood loss and its replacement is crucial to a successful outcome. And with that, that is the end of this lecture, and I thank you for listening and have a great day.